All right, good evening, everybody. I'm just going to give it another minute for some people to come and join, and then we'll start the webinar. All right, I'm going to start. My name is Bianca. I'm representing the Young African Nephrology Education Committee, and it's my great pleasure tonight to introduce you to our co-panelists. We are very honored tonight to have our palliative care colleagues come and join us to teach us a little bit about palliative care. And I'd like to thank everybody for taking the time this evening out of their personal time to come and chat to us. So the first person I would like to introduce is Pauline Renata. She's currently a nephrology fellow at the East African Kidney Institute in Kenya. She will be presenting our case tonight that will start the discussion around the challenges of palliative care within the African continent. Our two distinguished lecturers that will follow on is Professor Emmanuel Luyarika. I hope I didn't murder your surname. I'm sorry. He is a very distinguished guest who is an executive director of the African Palliative Care Association. He's a board member of the World Hospice Palliative Care Alliance. He served on several technical committees, including health ministries, the WHO, UNICEF, UNAIDS, to name a few. He believes in the importance of holistic care throughout the disease trajectory and improves patients' experience and quality of life. Our second distinguished guest is Associate Prof. Renee Krause. She's a good friend who works at Groote with me. She's currently the head of the Division of Palliative Care Medicine. She's a convener of postgraduate diplomas in palliative care, and she has an honorary appointment at Groote Hospital where she teaches and practices palliative care. As well as being a board member of the African Palliative Care Association and PALCare. So I'd just like to take the opportunity to thank you all for joining us today, and I'd like to welcome Pauline to start the webinar with her case series.
I hope the slides are visible.
Yes, visible.
Okay. So we'll start with a brief case. So the background is a female patient, 18-year-old, who has end-stage renal disease secondary to lupus nephritis. She's a patient who has experienced significant financial challenges and is currently a patient who requires twice-weekly hemodialysis, which she's not able to afford. So the patient is ZK, an 18-year-old lady who presented to our facility about a year ago with features of fluid overload. So the initial investigations revealed derangements in her kidney function tests, and as well as elevated blood pressure, and further workup for the underlying cause of the renal dysfunction confirmed that she has a SLE. So on the history of the presenting illness, she's a patient who reports to have had fatigue, general body malaise, and a skin rash for several months prior to this presentation. And that was closely followed by a history of progressive lower limb swelling, facial puffiness, and a reduction in the urine output that occurred about 2 weeks prior to presentation in the hospital. So the main feature that brought her to the hospital was shortness of breath, cough, and difficulty in lying flat. So on her family and social history, she's a second-born in a family of 3 children. The firstborn in their family is 20 years old, who is currently married with 1 child, while the lastborn is in primary school. So both of the parents are separated. The mother is alive, but she's battling a substance use disorder. And part of the medical expenses currently is being borne by the firstborn sister, who, as I mentioned, is just 20 years old and married with one child. She works as a casual laborer, earning minimum wage. So due to the significant financial difficulties, they are currently unable to sustain the cost of treatment as well as the day-to-day living expenses. So unfortunately, they have no permanent residence and they reside in a slum area in Kenya. So on physical examination, the vital signs showed a blood pressure of 149/76, a pulse of 98, respiratory rate was increased at 24, and oxygen saturation on room air was at 92%. She was very sick looking, pale, and she had bilateral pitting pedal edema. On the respiratory system, she was in obvious respiratory distress, and on auscultation, she had bibasal fine crackles. The rest of the systemic examination was unremarkable. So on the initial investigations, we did a full hemogram that showed a white cell count of 5.5, a HB that was reduced at 7.6, a normal MCV of 83.7, platelets were at 276. On the kidney function test, she had a sodium which was reduced at 126. Creatinine was elevated at 1,394 millimoles per liter. Urea was at 34 and potassium was at 4. Phosphate was also elevated at 3 millimoles per liter. The calcium level was reduced at 1.9 millimoles per liter. On the kidney ultrasound, it showed bilateral loss of corticomedullary differentiation with bilateral atrophic kidneys. Then on part of the workup for the SLE, we did an anti-nuclear antibody test, which came back positive. The anti-dsDNA also came back positive. The chest X-ray done initially showed features suggestive of pulmonary edema and cardiomegaly, and the blood gas analysis showed metabolic acidosis. So as part of our plan, we started her on hemodialysis in the year 2023, and she's currently undergoing maintenance hemodialysis twice weekly. She's also on regular phosphate binders, calcium supplementation. She's also on erythropoietin and iron sucrose weekly during the dialysis sessions. We also started her on a hydroxychloroquine for the SLE, and she's also on antihypertensives. So our main challenges that we have in her care is that the family is currently relying on the hospital to waive the expenses and also to give her credit services through the help of a social worker to be able to sustain the cost of dialysis. She also has to undergo daily cost of medications, investigations, and follow-up, which the family is not able to sustain due to the significant financial constraints. And finally, we've not been able to start any discussions on kidney transplantation, one, because of the family dynamics, and secondly, because of the significant financial distress. Thank you. That was a brief summary of the case.
Great. Pauline, thank you very much. You definitely are not alone with these tricky cases where we have patients running out of funds needing dialysis or those that we're unable to provide dialysis to. I'd like to hand over now to Prof. Lurica and ask him to give us a talk about what his thoughts are about providing palliative care in a resource-limited setting.
Okay, thank you very much for the opportunity. I'll share my screen and please confirm if you can see my screen.
Yes.
You can see it?
Yes, we can.
Okay. Yeah. Okay. So thank you very much. I'm going to restrict my presentation to designing an integrated plan and staff team for palliative care within a nephrology service. And then my colleague, Associate Professor Rene, will come in and put the specifics onto what I'm going to share. I'll start by talking about the definition of palliative care. It is an approach that improves the quality of life of patients, that is both adults and children, and their families who are facing problems associated with life-threatening illness, in this case, renal. It prevents and relieves suffering through the early identification, correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. That is the WHO definition that we still hold. And the point to note is the fact that both adults and children need it, and that the approach should cover physical, psychological, social, and spiritual problems that arise. The other, so I'll take you through a couple of objectives on, a number of objectives on in this presentation. We first of all need to understand the palliative care approach that keeps the patient and the family at the center, understanding the key components of a basic palliative care package for cancer, renal, and other diseases, understanding the steps in establishing palliative care service for adults and children, understanding the financial mechanisms and cost implications for a palliative care service. Our colleague has just talked about the financial aspect of the dialysis for this particular patient that she presented. We also need to be able to measure success and failure when we start a service. And then the main purpose of my presentation, defining the multidisciplinary staff team that you need. Apart from your nephrologists, you have the nurses and other professionals and partners and stakeholders within a palliative care service. And I'll make that clearer as we go along. So the approach within the context of nephrology should be able to help you anticipate the spectrum of needs that the patient will have. I'm sure the patient that has been presented is still at the back of our minds. This may be simple to diverse and complex, and we need to plan for them in a manner that is culturally sensitive. We also need to think of the needs of the family, including the spouse, the parents, the children, and other dependents, as well as the other primary caregivers at home, especially if the patient is one that is being cared for outside the inpatient unit, or if the responsibilities are shared by an inpatient unit and an outpatient unit. Then you design that staff establishment made of diverse multidisciplinary skills to address those patients' needs based on the disease conditions and processes. And remember, the staff you use may not be necessarily part of your staff team. There are other professionals within an establishment who may have palliative care skills and not part of your staff within the renal unit, but are willing to come in and support the work that you do, and you should be open to that. So in this approach, be clear on how you identify who can benefit from palliative care within your unit. So you need to look at the caliber of patients that you get and say, who will benefit from the service we are setting up. Ideally, palliative care should be provided from the point of diagnosis. That happens a lot within the cancer context, but it should also happen within the renal context, so that you just go on expanding the services you offer as the complex situations arise. You also need to assess the needs of the family members. We need to know the common symptoms to be encountered within the setting in which we work, in this case, the nephrology situation. We also need to be cognizant of the needs in terms of medicines that we need, which opioids shall we stock in case they are needed, and which psychotropics, which are they that will be used to relieve pain and other symptoms that do not make the patient's condition worse, but make the patient's condition better. And the plan should provide for general principles, and you need to be able to manage the underlying causes if it's still possible and is still consistent with the goals of care, the pharmacological and non-pharmacological treatment, to manage the symptoms, and giving attention to each patient's values and needs, not pushing it down the patient's throat, but making sure that we discuss all these things with the patient. And as I said at the beginning, the physical, psychosocial, spiritual, and other needs, including nutrition, should be discussed. What is this patient going to eat? What will they not eat? How will they access what they need to eat? And you know that nephrology patients, one of the issues is nutrition. Plan for caring and support for family members and caregivers too. That is very important. And also be clear on what you can do, you cannot do, but can be addressed through a referral system, partnerships, and networking with other providers. I'll go through briefly the package that was agreed by the African Ministers of Health at the Palliative Care Conference held in Kigali, Rwanda, which provides guidance for governments and other providers of palliative care. It is a costed package that is based within the recommendations of the Lancet Commission on Palliative Care, which had been published earlier. So you have one, the essential medicines, essential palliative care medicines. So you need to know what medicines you will need to manage symptoms. Pain medicines are important in the context of nephrology. Then you need to decide which pain control medicines will be used in case the patient has pain. Which ones will be used without actually accumulating more metabolites. You also need to look at the equipment that will be required, patient support devices and technologies, as well as supplies that the patients will need. And then that may also be determined by whether the patient's going to be at home or he will be coming in now and again, or is completely within your hospital context. You also need to think of how to use the mobile phone technology to offer better services, especially to family members. You need, as a renal unit, do you have a call-in service where family members can interact with you? Do you have an app that they can use to interact with you as the health provider? So all those are things that you need to think about. And then you also need to ask yourselves, do your patients have access to dialysis or other technology as a palliative modality within your service? And then you also think of other patient user or assistive devices and equipment and consumables. In case of patients, for example, have had cancer and they've lost a limb, or those who have lost hair, or those who need wheelchairs, or they need colostomy bags, those are issues that come up. What are they in the context of nephrology? And then you come to the human resources in your multidisciplinary team that you need. And then how will you use the disease survivors, people who have renal disease and are in a position to help other patients? Do you give them room to be patient navigators within your service? At times it helps when you have well-trained patient navigators to support other patients within your context. But also look at the psychosocial interventions, the spiritual care as may be required by the patients, and often, especially within law-limited settings, people need legal and other support. They need the legal support because it gets so expensive. We know that in Uganda, Kenya, and Malawi, guidelines have been developed by the government, and you just pick that and look at it and then know where to get legal support for the patient to deal with the issues that are not yet resolved within his or her context. And then you need to ask yourself, where am I? Are we in a rural setting, a peri-urban, or an urban setting? And that can help you to better address the needs of that patient. What can be available in the rural area may not be available in the peri-urban or in the urban area, especially in regards to services, but also in regards to food and many other things. Are you going to be able to extend your services beyond your unit and support a home-based care service, a community-based service, or you are restricted to a hospital-based service? Those are things that you need to work out early. Are you setting up a standalone unit, or you are integrating in within your existing service? And I think that is very important also to decide. And in whatever decisions you take, you need to ensure that you are able to address the needs of all your patients who come for the service. In terms of steps, you need to, first of all, understand the comprehensive approach, define your geographical location, and also be able to assess what you have within that location, and then plan to scale up and integrate palliative care into your existing healthcare system. Know where you get the medicines from. Is your hospital or your health service having those medicines? Strengthen the human resource that you have. Know the different cadres and what training they need. Define their core tasks and skills that you need to make available, and review links to primary health care within your context, because you cannot be able to do everything, especially if your patient is going back into the community. Provide for skills development, set standards, and plan to evaluate. Now we have the African Palliative Care has standards that are available on our website, and so you can use that to assess your system and also plan to measure the palliative care quality and feedback from patients and their families. In terms of financing, you need to ask yourself who is going to pay for the things that you are doing. Can they afford? Is there an alternative? Is it government that is going to cover that? Is it insurance? You can leverage existing public health system in terms of infrastructure, personnel, and then you integrate within that facility. Plan to know the unit cost of palliative care services to be provided. That is very helpful, especially when you are looking for supporters. They may ask you how much will it cost you, and then they give you a cost per patient offer. If you know that I spend $100 per patient per week, then it's easier for you to engage other donors apart from your traditional donors. Adopt key indicators for your program, and there is an indicator document by WHO, and also set up a system to collect data. For palliative care, most countries require you to report. Some countries like Uganda, they have a manual data collection system, which you can also make electronic, but that you are able to capture that information within your unit, so that then you can also be able to leverage the other resources because you are able to report. A well-designed M&E framework is good. Build measurement in staff capacity, in their tasks and roles, set targets, and also agree on the reporting mechanisms. How often will you report and to who, so that you can be able to become relevant. Also plan for support for staff to review developed reports internally, and not just for government and donors. They should be able to review how many patients do we get with renal problems who needed palliative care. What did we do? How did we do it? How the cancer survivors have been better trained than all the other groups. I don't know whether within the renal context in South Africa or other places we have trained them, but we can learn from them to be able to train other kidney patients or survivors to support those in palliative care, and then define roles for each stakeholder, so that you know the partners and their roles and what they are going to be able to do. And then identify strategic membership entities for the program so that they can be part of your support system and make it easier for you to deliver the service. Have your resources, tools, and information that can be accessed for all those strategic partners. And you can actually get some of those from the different stakeholders at no cost. Some of these things are available. For example, at APCA, you can ask, like I've said, the standards. How do you measure? How do you monitor and evaluate the training that you do? All those tools are available at the moment. And then plan for sustainability. It should be inbuilt. You need to think of how you make it sustainable. plan to draw more resources from the taxpayer because that is more sustainable, involve the community and partners within the community because then accountability and sustainability are better. Get involved with government people and structures right from the start because they have the biggest budget. A good and successful palliative care program is well grounded, is very well designed, and leverages available human and other resources, not necessarily putting a lot of money at the moment. You need to know the needs of the patient, know the resources at hand, know the constitution of your winning multidisciplinary team. Apart from the nephrologist, who are the other people that you need? You need a nutritionist, you may need a physiotherapist, you may need an occupational therapist, you may need so many people, you may need a chaplain, and those may be available and some at no cost. And then know how to measure your success and failure, and know how far you can go, both in terms of geographical reach, how many people can come to you, but also in terms of the package that you are offering. But also just know that this is possible, it can be done. I've attached some reference documents that you can refer to, both from APCA and the World Health Organization, as well as some of the other publications that will help you to achieve what you want to achieve. And also to mention that every 3 years we have an International Palliative Care and Allied Services Conference. This time it will be in Botswana in September. You'll hear more details about that, and it will be fantastic if you can be part of that, looking at the renal side of things within the context of palliative care, and also hearing what others have done within nephrology. Thank you very much.
Manuel, thank you very much for that talk. We're going to keep questions for the end. If you have any, please can you put them into the chat, and we'll have questions later. I'd like to welcome Renee Krause onto the floor to give us her talk. Thank you.
Thank you, Bianca, and thank you for allowing palliative care on a nephrology webinar. I think, as we have learned from oncology, we might be two different disciplines, but if we practice mutual curiosity, we will at the end really ensure that we get the best for our patients. Because like palliative care and oncology work together very closely, I think there's a space to ensure that palliative care and nephrology works very closely. And this is not only for the developing world, but we've also seen that this was triggered in high-income countries. So even if you have all the dialysis and transplant available, nephrology and palliative care doctors are working closely together. And in the developing world, there are palliative nephrologists currently. So thank you. We need to do this more. So many times people will say, oh, we can't do it. We don't have the resources. How are we going to now start something new? We are already running around. And I think we need to really change our mindset, as we've learned in our own setting, is that we can do this. We might not be able to offer our patients the most high-tech medications, etc., but we cannot abandon our patients. And in Africa, one of my colleagues always said, we are not resource poor, we are differently resourced. And especially when it comes to palliative care and the resources that we do need for palliative care, actually the African continent has a lot of resources. So let's just quickly look and see in more detail how palliative care and renal fit in together. Emmanuel started talking about this, but kidney supportive care is a word that's being used a lot currently in the literature globally. And kidney supportive care is the umbrella that covers hemodialysis, peritoneal dialysis, kidney transplant, and conservative kidney management. Conservative kidney management is care without dialysis or kidney transplant. And this focus of the care is on the quality of life and symptom control. So the patient that we heard that Pauline presented was a patient that needed conservative kidney management. And if we see how this now combines with palliative care, and Emmanuel has already sort of spoken about the definition, but our focus in this patient that Pauline presented should be quality of life. It should be patient and family. And above all, we must make this young girl suffering as little as possible. And she really had severe symptoms, distressing symptoms, not only for the patient and the family, but also for the healthcare providers who were looking after her, and a sense of helplessness when you don't know what to do further. I think when we go and look, and as Emmanuel also spoke about, is that we've got to decide who actually needs to follow a palliative care approach. And we need to start palliative care at the diagnosis when there is a life-threatening illness or a life-limiting illness. And in this case, with Pauline's presentation, it was a life-threatening illness. Now, this point where we really think we need to follow a palliative care approach is dependent on the context in what you are in who you are working. And depending on the context that you are working, it will be different. Therefore, whoever you say, I am going to start palliative care, you need to have consensus on, in your team, where shall we start following a palliative care approach. Now, this sketch is a very well-known, sorry, I just want to go, is a very known sketch where we understand that we are not going to cure patients, but as we become more, as cure becomes less important, the palliative care continues. And only a part of palliative care is end-of-life care, but this part is making sure the patient live as good as possible. And palliative care also doesn't stop with the death of the patient, but continues with bereavement care. Now, in our South African setting, we developed consensus on when we should start palliative care for patients. And again, the word consensus, because why is it so important that we all agree on where we should follow a palliative care approach? Firstly, it takes away that onus on that one doctor working in a nephrology clinic to say, okay, now I think palliative care approach is important. So it's not only on one doctor. And also it helps patients, and when everybody sings the same song and not the patients and the family don't get this conflicting information the whole time. So in the South African setting, we would say all patients stage 4 or 5 with deteriorating health, patients stopping or not starting dialysis, and kidney disease complicated with other life-limiting conditions or treatments. So Pauline's patient was definitely a patient that we would have thought from the beginning we should have provided her with palliative care, because we're going to have to stop dialysis. A very important problem in the African setting is that we do need to follow a principle of universal health coverage, where we know we need to have all our patients have access to rehabilitative, curative, preventative, and palliative care, but we cannot leave the patient or the healthcare system in financial ruin. And for us as healthcare professionals, it's very hard to see a patient dying and we want to throw all our resources at it, but we cannot leave that whole family in financial ruin afterwards. Also, we can't leave our healthcare system in financial ruin, which is very difficult as young doctors and as to see that, because it could be your family member that where treatment is denied. Very, very hard. As I said, it is the understanding the need of your renal patients within your context. And the need is not only the number of patients actually requiring palliative care. And we know that the renal registries are not well completed. We know actually most of the patients requiring renal transplant or renal care will not even come to a nephrologist, but in the African setting will only be seen at primary care level. So actually quantifying the amount of patients requiring a palliative care approach is very difficult. But the need is not only numbers. We really need to start listening at the stories of our patients and families. And for me, one of the things that stood out, and I think it's also relevant in the patient that Pauline presented, is it wasn't only the dialysis that was costing money, but the family had to come in. There were the blood tests. There were all the other treatments that were needed to contain the patient. So, and what was the effect actually on the family? What was that family's need and the social needs that also had to be addressed? So when we look at need, it's so much more than just how many patients that require palliative care approach, and what is the need of the family as well. So in our setting, the first step we did was decide, and it was myself, a professor from Sydney University, and Professor Nikki Wern, that we really decided we need to be on the same page. We had to show mutual curiosity in understanding how palliative care and nephrology works together. Because if we want to really change something for our nephrology patients, we have to advocate. It does not help if the palliative care team advocates and the renal team advocates. We have to do it together. And by following any approach, doing a we approach, we can then move policy. So I just want to show you how we developed a document on how patients should be cared for in South Africa with conservative kidney care. And the most important thing here is that you see lots of names. And this document has now been used to actually influence our standard treatment guidelines and essential medicines list. So building consensus within your own setting on what you can actually achieve for patients is fundamental as a first step for looking after your patients with renal palliative care or conservative kidney management. We also followed a different approach to look at who actually requires palliative care. And when we looked at specific indicators, because as doctors, we need specifics. We mustn't be hairy-fairy, we need specifics. We made a very important point in South Africa that the patient has to have a diagnosis. And that's why we made it very clear that palliative care would not be approached until we have a specific diagnosis. Because palliative care is not an excuse for poor care. And secondly, palliative care supports dialysis and advocates for dialysis and renal transplant as much as everybody. We want the best for our patients. And the circle of patients requiring palliative care, renal transplant, and dialysis is actually a circular approach. Because if you provide good end-of-life care and good palliative care in your ICUs, you are more likely to have people who are willing to transplant their organs. So developing the consensus and the circular approach is really there to improve the whole system for patients who actually require renal care and have access to dialysis and transplant. So now you will say to me, okay, so we've started a system, but we don't have palliative care doctors. We don't have palliative care nursing sisters, etc. And I think we need to look beyond that. And we need to say, how can I develop myself in palliative care as a nephrologist, as a palliative care person? And we are very grateful that the International Society of Nephrologists have created a free course online where you can specifically do certain modules on palliative care and nephrology. Wonderful course. It's for free. You can go and do it. There are other courses, and I think Emmanuel has already spoken about the APCA courses and webinars. We at UCT have online short courses. We've got diplomas, etc. But as a nephrologist, you are able to go and do a short course on palliative care on the ISN Academy. So please go and look at it and try and upskill yourself. However, to really practice palliative care, it's best you can see it being practiced. Seeing is believing. So try and find out whether you are in Tanzania or Egypt or Uganda, try and find out, are there palliative care leaders around you, and see if you can join them, or see how you can make them become part of your team so that actually you can start a palliative care approach. So it's upskilling ourselves and building those partnerships between the different disciplines. Building the networks of care, and I think Emmanuel spoke about building networks of care, but when we look at nephrology, firstly, management must be on board, because inevitably, when patients are not getting dialysis, when patients are not able to access the resources that they wish to have, that they see on Grey's Anatomy, there is anger. And I'm going to speak a little bit about the clinical approach and the anger that goes along with it following this, but make sure your management, your funders, your interdisciplinary team, your other disciplines, your community stakeholders, and your NGOs form part of this approach and are on board on how the patients should be treated and what treatment can be offered to them. Know how to refer to services, and I think in tertiary hospitals and even communities, people don't know how to refer out. People don't know what actual resources there are at the primary care setting and what resources there are actually at the NGO and community resources. Find out, speak, find out what is actually, where does your patient go to? Listen to the stories of your patients and their families and where they get their resources from. And remember, your palliative care teams will include your multidisciplinary team. Now, in Cape Town, what we use a butterfly system. So as soon as a palliative care patient is identified as a palliative care patient at the tertiary level, they get a butterfly stamp on their discharge letter. And at primary care setting, then that patient can be fast-tracked if they come for medication. It's a non-verbal way of communicating and ensuring that palliative care patients are not sitting in long queues, receiving the correct communication, and know that a decision has been made that this patient is not for max, as we will say. And it really helps patients to access community resources much easier. So service delivery, and I think many of the nephrologists are here. What do we do actually for the patients? So in Critis Care, we have palliative care teams, so people who are seeing patients in nephrology or on a daily basis, because the patients who require renal palliative care are not only seen by the nephrologist, they are seen by the primary healthcare providers, and they are seen by the general physicians. So on a daily basis, we see end-stage kidney disease patients, and they are not only seen in nephrology, they are seen in the cancer wards, they are seen in the surgical wards as well. As you all know, cervix cancer is a reality in our settings. So the symptoms and all these patients go, not all of, many of them go into renal failure. So you do need to have the skills on how to actually manage your medication, etc., across the hospital around end-stage kidney disease. But then also that we have dedicated time to sit with the nephrologists to see patients together. Now that creates two things. Firstly, it creates a space where we are teaching and training And secondly, it creates a space where we can learn from each other. So the mutual curiosity. And when we bring patients in to be seen, they have to bring their family members in. And it is usually, or many times, there's an element of anger that needs to be contained, especially from families. So it's the sadness and the anger that you need to deal with. We are very fortunate at Critics Care. We have an extremely well-trained, compassionate social worker that works with us, who knows the system very well. And so the interdisciplinary of seeing a complex patient together assists not only the patient and the family, but it assists the way that we as healthcare professionals are able to actually then manage that moral distress that comes into us when we cannot do everything for the patient. Okay, so the next step that we did that really works well, we created specific stationery. And again, you can see here, we've got that butterfly stamp that the patient goes on. But what it does, it recalls the decision-making tree that helps the continuity of the care. So when the next healthcare professional sees the patient, they know that this decision has been made and why the certain decisions have been made. What that then continues on is to give us an example of the common symptoms that we are expecting with renal patients and how to treat them. So, for example, our biggest issue with our renal patients are, of course, the swelling and the shortness of breath. And there is the dosages and how to manage the shortness of breath is given to patients and families. Now, these regimes are very easy to look up in any guideline. You can find them. But what we have found is that we do not have access to the drugs that are always mentioned in our international guidelines. Therefore, we need to develop some kind of consensus with the medication that is available. How are we going to treat them? So what are the common symptoms? It's the shortness of breath, it's the nausea and vomiting, and above all, the pain. Now, we know in South Africa and in Africa, we do not always have access to these complex drugs that are not renally accumulating. So therefore, we have to use the drugs that we have in a renal safe manner and develop consensus there. So for example, for the nephrologist and for me, it's okay, but think about where this patient is going to end up. This patient is going to end up in a small clinic with a very young nurse or doctor, and these complex patients are going to pitch up to them. So we need to give them a guideline on then how to treat the patient. But also by doing this, and I again just want to, we were able to in Cape Town get access to fentanyl, because what happened, we advocated for it. It wasn't the nephrologist advocating for it or the palliative care doctor advocating for other drugs. It was we who were advocating for it. Another big thing in our patients, and it's inevitable that everybody will ask you about eating. So making sure you have a pamphlet for patients on what to eat. It is across the world, we nurture by eating, and families want to do something. So we do always in these clinics have an eating discussion, eating and social, and has the family been informed? So having these specific clinics as to manage the patient and the family, to teach students, and to develop our own skills by learning from each other as a core element of a renal palliative care team. Working with families is probably in the African setting very difficult, and it requires an art, because it does require the communication skills. And if I ask you what is one of the big skills that a palliative care doctor or nurse or whatever brings to the table, it is communication skills. And especially when you have to convey difficult decisions, or when you have to use the family and the patient to make complex decisions, you need to have the correct communication skills to actually facilitate that conversation. And that is a skill, it needs to be taught. I want to recommend all African clinicians, please read this book of Christian Samara on an African framework for end-of-life care. It's a bit of tongue in the cheek, but it just shows that everybody is battling with these conversations and the complexities of working with families. And families are difficult. They come in from different cultures. They are in different phases of their relationship, of their own growing. And whatever we do, we need to make sure we are supporting this family, because not only are we managing a financial strain, a huge emotional strain, but many times we are also having vulnerable people in the family that really need to be cared for very carefully. And I just want to say, managing families is a skill as well. If you are unable to manage families, please ensure that you are working with your social worker and you understand grief and bereavement, you understand anger, all of those things, so that you don't become overwhelmed with the demands from families. Okay. As Emmanuel also spoke about, if you are starting a clinic, if you are starting to deliver palliative care, if you need to start advocating for whether it's for more dialysis machines, better access to medication, you are going to have a monitoring and evaluation system. So please follow a simple monitoring and evaluation system when you are providing a palliative care service. It does not need to be complex like this. You can have a simple Excel spreadsheet where you just number the patients you are seeing. Okay. When starting a palliative care or any palliative care service and you're walking into a new discipline, I really, from my experience, is that you start following an iterative approach, so that you start learning together. And making mistakes with starting a palliative care service is fundamental, because we are learning from developed countries. We figure out we can't implement it. It's impossible. We have to do something differently. And whatever we do, we can't say, oh, we don't have the money, or this is too difficult, or something like this, because above all, we can't abandon our patients. This is the time our patients really need us the most. So in implementing palliative care, in integrating palliative care, this iterative approach with the two disciplines become fundamental. As Bianca said, it's a coffee, it's a discussion, it's how can we do better? It's, sorry, we made a mistake. We won't do it again. We have learned from this. So please, we are still growing, and try and work together to bring better access to care for our patients, and having a we attitude instead of this is palliative care, this is nephrology. That does not work in integrating palliative care. Simple questions. We have to do research in renal palliative care, especially on the African continent, where there is so little access to dialysis, to transplant. How are we still providing palliative care to our patients with minimal resources? I just also want to say that palliative care is not just care. And when you start working in a palliative care setting and really working with patients with these high demands, high emotional demands, high family demands, look after your team. And especially when you're working with young nephrologists, young palliative care providers, young nurses or social workers, coming into this field is really a big issue. I have new staff at the moment, and the one said, oh, I was in a week in palliative care and I had to go and see my psychologist. You have to go and speak And if you are a senior nephrologist, make sure you are bringing in your team care as an essential component of care. And finally, I'm going to stop this lecture by saying, look after yourself. If you, as Pauline said, it was hard, we didn't know what to do. We ourselves felt tired, exhausted. How are we going to look after this young girl who's not going to be able to sustain her journey forward on dialysis? How are we going to sustain and support this patient and this family going forward? You cannot go through water without thinking you're not going to get wet. So please look after yourself when you are managing these complex patients, and know that we follow a principle of non-abandonment, and we never ever say to a patient or a family, there's nothing further we can do, because there's always something we can do for them. Thank you.
Renee, thank you very much. That was amazing, and Emmanuel as well, and Pauline. We have time for 2 questions. So I'm just going to open up the floor by probably starting with a tricky question by saying, a lot of the time when you as a nephrologist bring up palliative care, there's a bit of resistance from other nephrologists, because there's a train of thought that talking about palliative care lets government, lets institutions, lets funders off the hook of providing more dialysis. So my question to you is, how would you respond to other nephrologists that are trying to avoid palliative care because they feel that, they feel like they should be advocating for more dialysis and not less?
Thank you. I think that's an excellent question, and that's a reality. And I want to say that we do know that we advocate together for dialysis, but we also know that even patients on dialysis have complex symptoms, and their families also have complex symptoms. And we are not even going to dialyze everybody, okay? So even in the first world countries, as I say, palliative care and nephrology are working very closely together. It is only on that I'm finding in the Africa, because when I speak to my American colleagues and my UK and Australian colleagues, they are working together. They have realized, especially in elderly patients, in patients with other comorbid conditions, dialysis is not going to save that patient. You are going to have to follow a palliative care approach with these patients. But never is palliative care an excuse for poor dialysis. And the best advocates are always the palliative care people, because Emmanuel can say to you, palliative care is advocating as much for radiotherapy in Africa as the oncologists are doing in Africa. So it's that communal advocation. And when we are advocating, just to put my ICU hat on here, we are not only advocating for dialysis, but we should actually advocate for organ transplant as well, because long term we are also going to be the people, and that's what we're seeing at the moment in Groote Schuur, when palliative care or end of life care is well managed in ICU, then we have better access to organ transplant for patients. So it's a circular approach that we need to get right. Avoiding the topic of patients suffering actually does not solve the problem here.
Thank you for that. We have a comment in the chat about how frustrating it is to work in scenarios where even basic medications, even for conservative care, is unaffordable. And I think this ties into my last question for the evening for you and Emmanuel, about how would you start the conversation with Pauline's patient? And I know these are not easy questions, but how would you start that conversation with the patient and their family?
So firstly, I think before I start even talking to the patient or the family, I will sit down with my social worker, my nephrologist, my palliative care person, and my community person to make sure we all sing the same song. Because we have to have our facts behind us, and that's why our managers need to We need to have the good relationship, because Pauline said she was going to speak to funders, etc. So we have to find out what is the message we are saying to them. And this is a difficult conversation. So you need to have your time, you need to have your team around you, and again, decide who is going to lead the conversation. And there are skills, and I'm sure there are communication skill courses that I want to advocate that you do attend, but it's an ask-tell approach. It's making sure you acknowledge the emotions and making sure you give a very short, clear statement to the patient and the family about what the bad news is. We can't give dialysis. We will give dialysis for another 3 days or whatever, but a clear statement. We must not give false hopes to patients and families, because we have known from false hope, we are actually, our expectations actually does not create hope for patients. False hope is not good hope. So we need to be very clear that we give hope for patients that are achievable and within their own context. So those are the type of things, and that is a skill that you need to have, and be okay with your tissues and your water. But we need to have these difficult conversations. And when we've had the conversation, we emphasize non-abandonment. So we need to have a continuity of care pathway ahead. We need to have the medication to manage the symptoms. We need to make sure we follow up that patients, not from a curative point of view, but from a palliative care point of view for the patients. And that doesn't mean coming back to a nephrologist. I need to know who my resources are in my community.
Thank you. Emmanuel, do you have anything to add to that answer?
No, I have nothing to add. I think Renee has done a fantastic job putting all that in context.
Yeah, thank you. I think this has been a very thought-provoking webinar, and I'm sure there'll be lots of questions to follow. But thank you for your time, and unfortunately we have run out of time for today's webinar. But thank you for everybody's contribution and for taking time out of your day and your evening to come and chat to us. So I'd just like to end the webinar with a big thank you.
Thank you.
Thank you very much.
Thank you, everybody.
Do not forget about the Palliative Care Conference, September next year. Botswana, just look out for it, and the recording to this talk will be available. Great, thank you very much.
Bye.